Good afternoon. It's my privilege to be able to talk to you about the move from office-based labs to optimizing cardiovascular care in the outpatient setting. My name is Christopher Kwolek, and it's my privilege to serve as the Chief Medical Officer for a new vascular group here in New England focused on delivering outstanding care both in the inpatient and the outpatient environment. These are the disclosures related to this presentation. It is being supported by an educational grant from one of our industry colleagues in Philips Healthcare. So I wanted to give you an overview and a brief introduction to our group and why we chose this move to the outpatient care. I'll also give you a little insight as to the future directions I think we're heading in cardiovascular care, not only here in New England, but across the country. I'd also like to give you a brief overview of some of the equipment and facility that we found essential to being able to treat our patients in the outpatient setting. And then I thought I'd share a brief case presentation just highlighting some of the advantages of managing patients in this setting. So this is our beautiful facility here in Wellesley. We have essentially the 80% of the second floor, and this has allowed us to really focus on delivering care in an optimal environment for our patients. It doesn't require hospital admission. We have the ability to not only see patients in the office, but provide non-invasive diagnostic testing. And for many patients, we can treat their peripheral arterial or venous problems in the outpatient setting. They can come in with minimal sedation and local anesthetic, receive their intervention, and then have the ability to go home that very same day and spend the night in their own bed. And I will say that from a personal standpoint, our patients and their referring physicians absolutely love the experience, and they feel that they're getting the same, if not better care, in fact, because of our ability to pay attention to their individual needs. So I'll give you a brief overview of some of the pieces of technology that I believe are critical to being able to successfully perform these procedures in the outpatient setting. And I think at the very center of that is our imaging capability. And we had chosen to partner with Philips and their new Zenition C-arm system. What I would say is, from the standpoint of an interventionalist with 25 years of interventional experience, the quality of the imaging that we have available now in the ambulatory outpatient setting is as good as what we previously had in the fixed imaging system in the hospital. What you'll notice on the screen here is we have an 88-inch monitor on the wall with the ability to choose various inputs from live and reference images to intravascular ultrasound to standard ultrasound. We also have designed this as a teaching facility. You'll notice the camera on top so that we can have interaction with people in our conference room and zoom in on various parts of the procedure so that we can demonstrate new technology and new techniques. The other very important thing that Philips has been able to develop is a tableside control. And what you'll notice here is I can see my live image. I can adjust my contrast and filters. I can adjust my both fluoroscopy and subtraction angiography, both rate and doses. We're able to zoom. We have a detector laser available so that we don't have to use unnecessary radiation to center our images. And this has allowed us to perform everything immediately from the table side without relying on our technicians to have to adjust or make changes during the procedure. In addition, we're fortunate to be able to have access to the Volcano intravascular ultrasound equipment. And this has become invaluable, I would argue, not only in the management of venous disease to diagnose things like May-Thurner's, but in addition, I think it's become invaluable in the management of peripheral arterial disease. Many of you recognize that a consensus document was recently put out, initially discussed at Viva, talking about the importance and benefit of the use of intravascular ultrasound in managing patients with PAD. And I'll share a brief case with you that I think illustrates this nicely. So this patient was recently seen by us. She's 79 years old and has a long-standing history of hip and buttock pain with walking short distances, and also notices some discomfort in her calf. She doesn't have any gangrene or rest pain. She does have a concomitant diagnosis of spinal stenosis and has been working both with physical therapy, has had back injections. She actually tries to do Pilates several times a week. So she's really tried her very best to participate in a walking program, but still feels very severely limited. Her past medical history, as you might expect, is significant with both hypertension, coronary disease, hyperlipidemia, and diabetes. She's a former tobacco smoker and currently is on optimal medical therapy with aspirin, Plavix, a statin, and in fact metformin as well for treatment of her diabetes, and does have a family history of vascular disease as well. So on physical examination, she does have normal carotid and brachial radial pulses, but an absent left femoral pulse, very diminished right femoral pulse, and no palpable distal pulses, but by non-invasive testing does have distal perfusion. What you'll note is that her ABIs are about 0.6 bilaterally, but here's the other advantage. In our laboratory, we have treadmill testing. We can see that she has a decrease in her ABI to about 0.27 on the right, 0.36 on the left with exercise on a treadmill. So certainly consistent with pretty significant lifestyle limiting claudication. She's on optimal medication and really did not respond to a supervised walking program. So here's a diagnostic angiography, again, obtained in our facility, right femoral access on the far screen. You can see an aortogram with good views of the renals, and you can appreciate some calcification in the mid portion of the aorta and the iliacs. And she also has a little bit of bowel gas. And so you can see, at least by these angiographic views, I'm not certain how critical those stenoses are, certainly by history and by non-invasive testing. But if I was going by angiography alone, I'm not sure that I would be able to call a critical stenosis on either side. This is where I think intravascular ultrasound has become invaluable. So here is the intravascular ultrasound evaluation for this patient. What you can see is on the left side, on the right side of your screen, she has an approximately 80% stenosis. And on the right, about a 50 to 55% stenosis with a lot of heavy calcification. So when we're going to treat this, we're going to use a kissing balloon technique and kissing stents to minimize the chance of any plaque shift and causing problems on one side or the other. So what you can appreciate on the screen to the left is bilateral kissing balloons with 7 millimeter by 40 millimeter balloons. This is also where I think IVUS is very helpful, because I want to appropriately size, but particularly in an outpatient setting, I don't want to do something that would potentially cause rupture or something that could be a life-threatening complication. And so we don't want to aggressively oversize in this setting. So we went ahead and ballooned, went ahead and placed a 7 by 27 and a 7 by 37 millimeter balloon expandable stent, which you can appreciate on the right screen, and actually had quite a nice angiographic picture. However, we did use intravascular ultrasound again, and what we found was, particularly on the left side, that stent was not completely opposed to the vascular wall. And I think there is data out there suggesting that by fully dilating, safely expanding that, we can hopefully get better long-term patency and durability. So we went ahead and post-dilated with 8 millimeter by 40 millimeter balloons, again, very safely, very carefully. And this is her completion angiogram, where you can appreciate the excellent flow she has in both common iliac arteries. You can also appreciate an IMA stenosis there with a large meandering mesenteric vessel, and she does not have any mesenteric ischemia symptoms. We were able to do this with percutaneous access, percutaneous closure devices, ultrasound-guided CELT on the right, a star close on the left, and we can talk at another point about choice of closure devices and why I use certain devices in certain types of anatomy. But I thought this illustrated nicely a case of how we could treat a patient who is extremely symptomatic safely, quickly, efficiently in an outpatient setting with excellent anatomic results and an excellent clinical result. I wanted to welcome you to the vascular care group at Newton Wellesley Vascular. This is a 10,000 square foot facility located in Wellesley, Massachusetts, designed to provide sort of state-of-the-art care for patients with vascular, arterial, and venous vascular disease. So here you'll see the entrance to our waiting area. This is where all of our patients come in for registration prior to any evaluation in the clinic. In this facility, we have 6 examination rooms, as well as 4 vascular ultrasound rooms that allow us to evaluate and diagnose patients with both arterial and venous vascular disease. In addition, you'll see our office-based laboratory facility where we have a recovery bay capable of taking care of up to 5 patients and 2 interventional suites that allow us to treat the full spectrum of arterial and venous vascular disease. So here's one of our typical examination rooms where we can see and evaluate patients with both arterial and venous vascular disease. This is actually one of our venous treatment rooms. It's one of our 4 ultrasound rooms that we've converted into a treatment room for patients with saphenous vein reflux. So you can appreciate that we have the ability to do bedside ultrasound and venous ablation procedures as well as cosmetic procedures, and again, allow patients to go home the same day. Here's our pre and post recovery area. So prior to intervention and then after intervention, there are 5 bays that allow us to take care of patients both with hemodynamic monitoring and post-procedure care prior to their discharge. Next, we'll take you into the procedure room. One of the things that we've very much liked about the Zenischen system is its ease of use. The controls are very intuitive. As I mentioned previously, we actually have the tableside controls so that I can control both my table in terms of position and height and elevation. We can also rotate the image intensifier. So if we need oblique views or oblique angles, we can achieve that very quickly and easily. The image quality is superb compared to what we've previously experienced with C-arm systems. And for me, probably one of the biggest selling points, again, is the very, very low radiation dose that both our patients and our staff receive when utilizing the system while maintaining outstanding visualization and images. So I think that is probably the most important factor from my perspective. As you notice, we also have this room set up so that we have an 88-inch monitor on the far wall. We have a second 55-inch screen, and we have an information system that allows us to integrate input from the C-arm, from the intravascular ultrasound, from the bedside ultrasound that we use for access and closure devices. We've also installed an overhead camera above the main 88-inch imaging panel that allows us to be able to teach and educate. So we've integrated a fully automated conference room where we can have exchanges with industry colleagues, with students that allow us to teach and train in this facility as well. We do have 2 additional overhead integrated cameras that allow us to zoom in on the procedural field. So whether we're demonstrating a new stent or a new device or a new technique, we can both teach and train to that as well, and obviously have the ability to record these sessions for later training purposes. So I think the combination of these imaging components as well as an integrated audio system allow us to be able to communicate with both trainees or staff in the conference room while we're actually performing a live procedure. And then we have the ability to maintain, patient confidentiality by utilizing a headset so that we can be communicating with trainees and others, but without having our patients having to listen to or overhear that conversation. So you'll notice the high quality of the imaging system on the large 88-inch monitor, the ability to use integrated IVUS on the 55-inch monitor, the Barco integrated system that allows us to choose the multiple inputs from about 9 different inputs. We can put those on our conference room screen, our 55-inch screen, and our 88-inch screen, and we can individualize that depending on what we're trying to teach and train to. So this was very specifically designed, not just with the patient care experience in mind, but with training, teaching, education for residents and students, for other physicians out in practice, and also for our industry partners and colleagues, as many times they're trying to learn and evaluate new technology as well. And it has become incredibly challenging in this day and age to try to get into hospital systems with COVID and all the other restrictions. And we're able to do that much more safely and quickly and efficiently than some of the large institutions. The other thing that you'll notice is we have been able to cooperate and collaborate with industry so that from an inventory standpoint, we are able to work well with numerous partners. We've standardized our supply chain and standardized our ability to work with various colleagues so that across the system, we have a pretty standardized inventory of technology and equipment. But I would argue that in this OBL setting, I have access to as good, if not better, technology than I've ever had in any of the tertiary or community-based interventional labs that I've worked in. And part of that is just industry's willingness to partner and realizing that this is the new frontier. This is the new way that we will be managing patients for not only vascular, but soon cardiovascular disease. Mm-hmm. So again, from our perspective, the ability to partner with our industry colleagues, both in terms of catheters, balloons, wires, stents, imaging technology, is a critical part of moving this field forward. This is also an opportunity for us to reach out to our colleagues across other specialties, our colleagues in podiatry, our colleagues in wound care, our colleagues in diabetes and endocrinology, our colleagues in renal medicine, our colleagues in cardiology, just to let them know what's actually available in the outpatient setting. We often take it for granted that people know that we're here and know what's happening or what we're doing. But what we found is, surprisingly, even though we think we're doing a good job of outreach and education, we can always do more. And that's why we're grateful for partners like yourself who can help us spread that word and let people know what is possible. I realize many of our colleagues across the United States, in the Midwest and in the South and in the West, are further ahead than many places in New England. But I view that not as a detriment. I view that as an opportunity for us to continue to grow and evolve and help educate and train others in terms of the advantages of practicing in this outpatient environment. And all of us still work in an inpatient setting, take care of patients both in and out of the hospital, but this allows us to more effectively structure our work weeks, more effectively structure our days, more effectively take care of patients in an expedited fashion, because the ability to add many cases on in the inpatient setting is often very, very dependent on multiple factors, including anesthesia, other major cases happening in the OR, bed availability, to name a few things. And so I think we do have the ability to be much more flexible and adaptable in the outpatient environment compared to individuals who are solely practicing in an inpatient setting. So once again, I do think that every single institution in the country will have to figure out ways to allow and enable their physicians to have access to outpatient office-based facilities so that they can more efficiently and effectively practice vascular disease management. So I just wanted to thank you for your attention, and I hope you'll have a chance to visit our website, and I'd be more than happy to talk or answer any questions that you might have in the future. Please feel free to contact me either via our website or via LinkedIn. Thank you very much.
This webinar series, Practical and Visionary Views of Out-of-Hospital Care, is sponsored by Philips OBL and ASC Solutions Symphony Suite, the leader in out-of-hospital solutions. We provide customers with the expertise they need and a partner they can trust in opening cardiovascular office-based labs or ambulatory surgery centers. Ready to get started or want to learn more? Visit philips.com/Symphony Suite.